Thank you. You may be seated. And we are back on the record. Sir, I remind you, you're still under oath. You may proceed.
Good afternoon.
Good afternoon.
I think you heard me introduce myself earlier, but I am Amy Cash. I'm here on behalf of the government. Just a few housekeeping type questions. Who retained you for this action?
Chris's law,
How much are you being paid for the testimony?
0.
Were you given any instructions for your testimony or any materials to review?
No.
Now, you were very obviously an accomplished industrial hygienist, but you mentioned that you do, that will include work in epidemiology, perhaps public health. Do you consider yourself an expert epidemiologist?
Yes. I've been qualified that way before, yes.
What cases have you been qualified as an epidemiologist?
Roundup, Ponce-8. That question gets asked every time. Same answer on a lot of testimony.
And are we talking about the exposure issues in Roundup?
You can't practice as an industrial hygienist. First of all, you're tested on it, but you can't practice without knowing epidemiology. Otherwise, you can go out into the workplace to know what's associated with what. It's a requirement as an industrial hygienist.
Okay, well, let's take a step back and talk a little bit more about what industrial hygiene is.
Sure.
It's not, I would explain industrial hygiene as the application of OSHA standards, practices, regulations to individual workplaces or situations to see what is going to be the best or the required outcome. Would that be fair?
No.
Okay, how would you correct me?
Take a long time. Let me give you an example of a benzene case I'm working on now. I interviewed the individual. I reviewed 10 or 20,000 pages of documents. I reviewed, I have libraries of documents. And each library is over 10,000 documents. From his DSs, whether it's exposure. I reviewed the pertinent papers. I did calculations. I've written a preeminent paper on Mark Nicholas on dermal exposure. So I think I'm the only one in the country that, since Mark just retired, that still does dermal analysis. So I'll do detailed dermal exposure calculations. On the Roundup, I do exposure calculations. The warnings is just a small piece of it.
Okay, so when you're talking about doing these exposure calculations, you're talking about doing them in a specific application. Is that correct? Like where you've got a plaintiff who is suing about his exposure to Roundup or to benzene.
Or if it's a defendant, yeah, either way.
Okay. So you're not,
That's part of industrial hygiene.
correct. And that's what
It's
I,
not just PPE.
oh, yes.
Tells declared the CSP is the gold standard for OSHA.
But you're not talking about, in these situations, creating, say, an OSHA standard or proposed OSHA standard for benzene exposure. You're talking about whether or not an individual person received a sufficient dose or received an exposure above allowable recommended.
Yes and no, it's much more complicated.
I know you're the expert, so can you tell it to us in a simple way?
Even the exposure itself is to be as simple as time with materials of concern. The first thing you have to do is make sure that the exposures are consistent with the disease. So that's the epi side of it. words, I can't do calculations on something that nobody's ever shown across that disease. Exposure can be simply as little as time with material. It can be looking at the composition of the materials and integrating all of that. It can be inhalation only, inhalation thermal, inhalation thermal congestion. And then on the PPE side, you have to go through the whole gauntlet of what the PPE was that was available at the time, go through the history of the PPE regulations beginning really with the WAPI standards in 1945, legal and professional information, which then resulted in the ANSI 129.1 standards, which then resulted in the OSHA standards in the 1970s. So you have to go through that whole history and see what was applicable at the time and what was actually used at the time and compare and make those differences. So and then you make recommendations on what should have been done. Sort of protection should have gone. So, and then you look at individual MSDSs and labels and look at individual language and see whether or not that language is consistent with regulations. Both regulations as well as the standards that we have for us.
Again, we're talking about doing this analysis in the context of a proposed exposure or a supposed exposure. When you're talking about the plaintiff or on the defense side, you have someone who's alleging a specific exposure. Is that fair?
In those cases, but if I'm doing HVAC analysis, that's something totally different.
Okay. How would you explain the difference between OSHA and public health to us today?
Explain what your question is. I don't know what you're asking.
Okay, that's fair. What is OSHA?
Occupational Safety and Health Administration.
Okay. Where do OSHA standards apply?
To workers.
What about public health? What is your understanding of public health rules and where they apply?
I don't know if you're speaking, what rules are you talking about?
Public health rules.
Understand, that's like saying, fine for the air. Well, I need to know what air you're talking about. So on the public health side, what agency and what rules that apply?
Well, we're here to talk about the Kentucky Department of Public Health as well as the governor's emergency rules.
Okay.
So rules promulgated by the Kentucky Department for Public Health.
I appreciate it. I'm here to talk about PPE and exposure. That's what I'm here for. That's what I've opined on. I haven't opined on the rules. I've just simply opined on the efficacy of masks and under industrial hygiene standards, as well as what really should be done. That's what I've opined on. I haven't opined on rules one way or the other.
Okay, so you are saying that you don't know what Kentucky's public health rules are?
I may not know specifically what the individual rules are. No, I'm opining specifically on the effectiveness of masks and what should have been used instead.
Do you know what rules Kentucky put in place for COVID-19?
I think I just answered that question. I'm not here to opine on the Kentucky rules.
Okay, so you don't know if Kentucky instituted the types of engineering controls that you said in your direct testimony were your preferred alternative?
If they would have, they wouldn't have the mask mandate.
Well, you can't really testify as to what they would or would not have done. Is your answer, you don't know?
No, I can. I'm here to tell you that anybody with an industrial hygiene background would not recommend masks. They really wouldn't.
So
Because they don't even fit on the hierarchy of controls. So you say, well, so all I can tell you is based on industrial hygiene rules, the key is engineering controls, destruction and illusion. Period. Not masks. That's what I'm here to opine on. And I think that, I made that case.
And I am asking you, do you know if Kentucky recommended engineering controls during the COVID-19 pandemic?
To what extent did they recommend it? They, in the sense that I've heard that they recommend maintain a safe distance. I don't know what that means. be honest with you. With
Have-
aerosols, what does it say? Please
Have you read any of
I just want to
Kentucky's
finish,
guidance?
please.
I'm sorry,
let me finish.
we can let each other finish, so you can go first.
I'm done. But I would like to finish my answer before you go.
We finished. Have you read any of Kentucky's guidance other than its mask rules?
I think I've answered that question multiple
No,
times.
you haven't. Have you read Kentucky's guidance related to COVID-19 other than its masking? It's a very simple yes or no question.
And I said, I'm not here to talk about Kentucky rules.
You said you're not here to talk about it. You didn't answer whether you had read it.
I can't recall if I did or not. That wasn't my focus. My focus was on, I've read a lot of rules, whether I've read their specific, I read the most recent thing about the June 11th issue. But whether I can recall back on that or not, I just don't recall. But that isn't my focus here. My focus is massive effective.
Well, we are allowed to cross-examine you and ask you questions about what you did to come to your conclusions. And that's why I'm asking whether or not you looked at the context of Kentucky's masking rule. And it's apparent you did not.
Well, I think I just answered it. I know that's the same answer I just made.
Do you think COVID required any interventions?
That question is broader to me because it has medical aspects as well as industrial hygiene aspects. On the industrial hygiene I cited it, I certainly do, and I think it's engineering controls. And that wasn't what was adopted.
But you just said you didn't read to know what was adopted, if there were engineering controls adopted.
No, you twisted that. I just answered the question you just asked, whether or not we could go back and ask and look at the question you asked. I think I answered it.
Do you believe that regulators have a learning curve related to COVID as an novel virus?
Objection, Your Honor. If I heard a question, the regulators have a learning curve, I think that's beyond the scope of anything an industrial hygienist could reasonably be asked.
3 months.
He's here saying he understands OSHA rules and OSHA's regulation. I can narrow it to OSHA. Do we believe that OSHA had a learning curve where COVID was concerned, if that would resolve the issue?
It seems outside the scope of his expertise, but there was lengthy direct examination. It is cross-examination, so I'm comfortable with answering it.
If it's limited to the OSHA question, Your Honor, I would go with that.
Yeah, I don't know what's in the minds of the OSHA individuals, and there's lots of people at OSHA, so I don't know how to answer that question.
Do you accept the CDC as a organization with scientific validity or authority? In general.
I don't know how to answer that question. I think CDC has, they certainly have scientists. It's a big entity, and I wouldn't know how to answer that. If you ask me about a specific position they had or the specific individual statement, then I would reply beyond that. If you're just asking a global question, I wouldn't know how to answer that.
But you've said here today, and correct me if I'm wrong, that you believe they missed the mark on masks.
Oh, yeah. And I think they know it based on their writings.
Is your opinion universally held among industrial hygienists?
I haven't surveyed industrial hygienists, so I wouldn't know. All I can tell you is I have sent my presentations over the last year to all the major law firms I work for, and nobody's disagreed.
So you are.
But beyond that, I first of all, I don't know how many industrial hygienists are, because there's a huge difference between an IH and a CIH. And even in the CIH, I think there's on the order of 10,000 CIHs. So I talked to the president of the Industrial Hygiene Association, and his position is that engineering controls dominant. So I've actually spoken to him in the last month. But I don't think and I asked him, because he claimed in a public notice that he had surveyed the industrial hygienists, and I said, "We've never been surveyed." And he said, "Well, we didn't really survey them." So to my knowledge, the IHA would be the organization to do it.
So you're here today, I mean, obviously giving your opinion, but you are not stating that this would be generally the opinion of most industrial hygienists or even any other industrial hygienist.
Oh, I mean, I can't speak for them, but I'm here to tell you that nobody would disagree with the hierarchy of controls as the approach to take from industrial hygiene. If they do, then they're not very industrial hygienists.
Even among the hierarchy of controls that you've talked about, there are still uses for these level controls. Wouldn't that be right?
Which one are you talking about?
I'm talking in general when we're talking about a hierarchy of
Well,
controls.
what's the lowest one you're mentioning?
Well, here,
So I need to have a specific.
You mentioned in your context PPE, actual PPE, like an N95, tested N95, sitting inside masks. Are there applications for that?
For respirators?
Yes.
Certainly, but as a last resort until you take care of the problem by engineering controls or other means. I mean, it's always, PPE is viewed, in general, PPE is viewed by industrial hygienists as sort of like the last resort in sort of an emergency situation until you can actually solve the problem. You don't want people indefinitely wearing respirators. They won't wear them effectively over long periods of time, and that's been shown in other studies. So you know that if you're going, almost all the time that people recommend PPE, they recommend it for emergency use, if you will, until they can solve the problem with other means.
Okay, so you're saying that there are applications for PPE, for example, when the other controls are insufficient, at least in an emergency basis.
It's fluid, but there's certainly, PPE is intended to be used as a last resort, and generally in emergency type situations, that's correct.
Have you done an epidemiological literature research on masking in the COVID pandemic?
I don't know what you're asking.
Have you researched epidemiological literature about the efficacy of masking during the COVID-19 pandemic?
Sure. I
Would
mean,
you-
the only study on the epidemiology side that meets the privacy criteria is the Denmark study, which is a double-blind study. So, to my knowledge, it's the only double-blind large study that's been done.
Are there
And
other,
it shows there's no difference in rate of contracting COVID between people who wear masks and those that don't.
are there other studies that don't meet that criteria, that weren't double blind?
I can give you studies that I've looked at that are, there was one study done, sent to me, on New York State, where they claimed that masks work, but what they did is they looked at the disease progression curve. By that I mean, if you look at time, the number of cases or number of deaths, they slowly rise to a peak and then they tail off. What this study did, two guys from Texas Tech, they assumed that at the peak of the disease progression curve, masks started being used, and all of the tail off was because of masks. Well, I wrote back that this was nonsense, that this was simply the fact that with time, disease tails off. You couldn't associate, first of all, you can't pick the moment in time when it's the peak. So there's been studies out there.
Are you familiar with a February 10, 2021 publication in JAMA by John Brooks and Jay Butler regarding the effectiveness of mask wearing to control community spread of SARS-CoV-2?
Not necessarily, but if you want to show it to me, I'll look at it.
Personally, I don't have a copy of it, but I will read you a segment of that, and I can hand you my phone if it would help after, because I know I don't.
Well, I would want to see the whole study. I don't think that's fair.
Okay.
And
Did you include whole studies in your report?
Absolutely. I did because I attached things to it and I brought them.
And Your Honor, I would interpose an objection. If council intends to present any excerpts from any treatises or articles, we're entitled to see the whole thing before it's introduced into the record in any way.
I don't believe that's an issue currently, but your response?
We obviously had no notice who the witnesses were going to be. We can submit that into the record after I've given the site. They will let them on, like they do the testimony.
I don't believe she has any documents to be presenting here in court. To the extent the objection is that she would be acting with the officer based on the
I will represent to you that in this article, it's talking about the Denmark trial that you just mentioned. And it states, this randomized trial in Denmark was designed to detect at least a 50% reduction in risk for persons wearing surgical masks. Findings were inconclusive, most likely because the actual reduction in exposure these masks provided for the wearer was lower. More importantly, the study was far too small, i.e. enrolled about 0.1% of the population to assess the community benefit achieved when wearer protection is combined with reduced source transmission from mask wearers to others. Do you disagree with that characterization of the Denmark study?
I do, but I would want to see the entire paper before I commented on what this author said. The fact that that the study, as I understand it, is one of the most robust that's been done. There were 6,000 people involved, 3,000 with masks, 3,000 without. At least that's how it started. And whether or not what the percentage of the total population is not, I don't think. I mean, that statement is, to me, everything after the words "but" are just conjecture.
What is your explanation for the fact that the World Health Organization, Centers for Disease Control, and almost every single state has recommended masks at one point or another during the pandemic?
I'm not in their minds. I think you're seeing it fall apart rather rapidly as people like myself go public and show the actual science. I don't believe any of those recommendations were based on real science. I really don't.
But you just said you're not in their minds. Do you know, have you analyzed what each of those recommendations is based on?
They don't provide a basis. That's the scary part about it. I've read as many papers as I can get my hands on. I've read. Just like when I talked about the 6-foot rule, I've gone through and looked at it in history for a year on where that comes from. CDC doesn't provide a response on where it comes from.
The paper I am, strike that, I'm on the wrong one. The CDC's current mask guidance published on May 7th, 2021 does include citations. But they're saying they don't give citations for the.
Oh, I looked at that. There were 2 citations with the justified mask. One of them was an interesting, I don't know if they used Tyndall lighting or what, but they showed somebody with a mask and they showed a picture of Tyndall lighting, the projection of the particles with and without a mask, showing that it's shorter on a short-term cough and saying, see, masks work. And I'm like, no, because what's a 1 second snapshot mean for those emissions as they continue in time? I mean, one of the 2 papers, I looked at the 2 that were tied to that guidance, and both of them don't prove what they're saying.
There are actually 15 studies cited in the guidance I'm talking about, not 2.
No, there's 2 that are directly tied to the efficacy of masks, as I recall. There are 15 studies, but 2 specifically, I think 3 and 5 or something like that, are tied to efficacy.
Is there a distinction between looking at masks in a vacuum and how they overlay with other public health interventions?
I don't know what you're asking.
No further questions from me.
Any redirect, ask the questions, ask for us.
No, Your Honor.
Does the plaintiff have any additional witnesses?
We do not, Your Honor. I don't know if you wanted us to move to admit exhibits now or at the conclusion of the defendant's proof. It might make sense. I know the defendant might put some evidence in, and we may use some additional exhibits, so I don't know if you want to wait at the end.
Are there any stipulations as to this?
I mean, our only objection would be to exhibit 26, where we don't have the sources of the information. That otherwise, I think as far as the, any exhibits, anything that's been talked about, CVs and everything, we have no objection to that.
So with regard to exhibit 26, what's your response to that?
Your Honor, I think that she did lay a foundation. She reviewed it. And my recollection of her testimony was that she did review it, and she looked at census data and public CDC data on the number of cases and deaths was the basis of it.
She didn't prepare it, and she also couldn't say 100% for sure. She did prepare it, and she did not understand why the different states were selected.
Based on that, what would be the specific rule of evidence under which I could accept this as an exhibit?
Your Honor, she indicated that she reviewed it for its accuracy and therefore was able to rely on it as an expert. And Your Honor, I believe it's 703 or 704.
I have no doubt that she relied on it. I just believe we showed that she could not demonstrate it was reliable and the type of information that an expert in the field would provide.
Okay, I have concerns that an appropriate foundation was laid and that there was sufficient testimony as to her confirming the materials or the data that's in that report. I want to look at the transcript or the hearing to confirm that. If that was in fact confirmed by her testimony, I would probably not do that. Otherwise, my recollection isn't that she precisely said she confirmed the data that's listed in here, but she did testify that she didn't prepare it, wasn't sure who did prepare it. So, as I sit here now, I would have to sustain the objection, but I could reserve on it until I watch the tape.
Your Honor, my recollection is that she did indicate that she reviewed it for its accuracy and that it matched CDC and census data. So I realize what the tentative ruling is, but I would ask the court look at that testimony.
Okay, I'm gonna then go forward based on my ruling, but I'm reserving on it that when I watch the tape, which I probably will, I'll just confirm and I'm gonna reserve as to whether or not I will allow it based on that. But as I currently sit here, I'm gonna sustain the objection.
Thank you, Your Honor.
All other exhibits are admitted. Does defense have any witnesses you would like?
Yes, sir. Excuse me, we would call Dr. Stephen Stack, please.
Okay. Clerk calls Dr. Stephen Stack. Doctor, please seated, please raise your right hand. Do you swear or affirm that the testimony you're about to give will be the truth, so help you God? Okay. You may proceed.
Okay, please state your current position.
I'm the Commissioner for Public Health in the Commonwealth of Kentucky.
And how long have you been currently employed in that position?
It's February 10th, 2020.
Can you briefly tell the court your educational background, starting bachelor's degree forward?
Yes, sir. I have an undergraduate degree from the College Holy Cross in classical studies and pre-medical studies. I have a medical degree from the Ohio State University. I did my emergency medicine training at the Ohio State University and I'm board certified in emergency medicine. I also have a master's of business administration from the University of Kentucky.
Where were you employed prior to coming to the Department of Public Health?
I was an emergency physician working in a number of hospitals, including St. Joseph East in Lexington, Kentucky, and also the Christ Hospital in Cincinnati, Ohio.
Okay. Now, can you kind of give a brief description of what your job duties are as the Commissioner of the Department of Public Health?
So I'm the principal executive officer overseeing the operations of the Kentucky Department of Public Health, which includes numerous divisions and functions for public health in the Commonwealth of Kentucky. And the capacity of COVID-19, my department has many of the areas of expertise and authority for overseeing and recommending courses of action for the COVID response.
If I recall correctly, you came into your current position about a month before the state of emergency was declared in March of 2020. Is that correct?
It is.
So you've been there from the beginning of the current state of emergency.
That's correct.
Can you explain to the court what COVID-19 is and how it works again?
COVID-19 is a viral infectious disease that is spread most commonly by droplet infection or droplet transmission or airborne transmission. It can be aerosols as well. It can also be transmitted by touching contaminated surfaces that have virus and then touching the mucous membrane like your eyes, your nose, your mouth. The disease itself predominantly is a respiratory infection, but also has involved people's central nervous system, their gastrointestinal tract, and other organs. It's been a global pandemic since sometime very early last year.
Very simply, based on your experience and your day, what is the best way to mitigate the spread of COVID-19? Some of the tools used to do that.
Your Honor, I object, at least until or unless they proffer as an expert. And then we may have objections on that.
And then what?
We may have objections on that, but we haven't crossed that bridge yet.
Counsel.
Your Honor, that question was posed, and I'm asking Dr. Stacks here today in his official capacity. He is the Commissioner of the Department of Public Health. As he has stated, he has been in that position since the start of the pandemic and the start of the declared state of emergency here in Kentucky. There's nobody better to specifically address the factual question of what DPH, Department of Public Health, has done during the pendency of the current state of emergency. He's not here to offer opinion. He's here to as a fact witness about what was done by DPH, the steps they've taken, how they interact with certain federal agencies and regulatory agencies. That is the purpose of his testimony here today.
Your Honor, which all of that may be fine, but the question that was asked was specifically an opinion testimony regarding the spread of COVID. And to that, right now, unless he's an expert, we don't believe that he's entitled to give opinion testimony.
I can rephrase the question. I think it might be the simplest way to so you can move forward.
You may sustain.
What has been the Kentucky Department of Public Health's role in responding to the COVID-19 pandemic?
So the Kentucky Department for Public Health has had numerous roles. It has been to evaluate the public health impact of COVID-19 as an infectious disease. It has been to recommend interventions that might mitigate against the harms caused by COVID-19. And it has been to provide guidance and at times requirements for the public to follow to try to help apply those mitigation strategies.
What are those strategies that the EPH has tried to spread the word on?
So those strategies have to do with essentially keeping people apart from each other, because when people come close to each other, that's how they spread disease. And so there are different ways to do that have included reducing the numbers of people who have gathered together in certain settings or environments, increasing the space between people to lower the likelihood of transmission of infectious disease between them, instituting barrier precautions, most commonly the masks that are barriers on each of our individual faces to keep infection to us if we have it and not spread it to others, or to at times minimize the transmission of infection from others to us. Plexiglass barriers like are on the just asked there, surface cleaning interventions, infection screening tools for guidance so that people who they enter certain environments check themselves for infection or are checked by others for signs of infection so they don't contaminate or expose others to the infection. And a number of other tools such as contact tracing, disease investigation, and others which are quite helpful.
Now, has the Department of Public Health as far as managing a statewide response, explain the interaction between DPH and CDC.
So the Centers for Disease Control is a federal agency that is comprised of a number of public health experts who provide expert guidance and information and education for the nation. Those guidance documents are then used by others who are physicians like myself across the 50 states and the territories of the nation to translate that into the context of our specific states with their unique regulations and statutes.
And just for a little background, explain how the Department of Public Health interacts with the number of local health departments here in Kentucky.
So we have 120 counties that are served by 61 local health departments. Some are single county and some are multi-county districts. I routinely communicate with those leaders, the health commissioners for each of those 61 health departments, sometimes individually, sometimes in groups, so the entire body convened. And the multiple hundreds of staff people who are at the State Department for Public Health interact with the multiple thousands of people across the local health departments through a number of other regular communications to share information, provide guidance, and to confer with each other on recommendations to be taken.
Do you provide any tangible resources to them, such as PPE or things like that, as far as resource provision?
Yes, so we have provided, in the context of personal protective equipment, earlier in the response, we and every other state undertook a substantial effort to acquire PPE, so we had it to support public health, but also to support the healthcare system. We also, though, provide information technology support. We built an entire contact tracing IT platform, which is the first time the entire state that had a technology platform to share that sort of information to coordinate our activities and be more efficient and effective. We also do numerous clinician education sessions to help educate physicians and other healthcare providers on the recognition, diagnosis, treatment, prevention of COVID-19, and there are numerous other avenues through which we can.
And from the time the pandemic began to here we are today, can you describe how the DPH response has evolved since the beginning, since March of 2020?
So as I've said before in other settings, including this court, this was a disease that was not known in the human population until late 2019. So when the emergency response began in the state of Kentucky in early March last year, there was a great deal that was unknown. What was known was that an entire Chinese province had been overrun by the disease, and they quarantined a province of about 30 million people in Wuhan, China, in that province. And so there was great concern because the disease spread rapidly across the globe, and within 2 months was already in New York and Seattle. And great concern because of what had been witnessed in other countries, first China, but then Italy, and then others, about this substantial distress that caused healthcare systems when enormous numbers of people severely ill from COVID arrived. People were not familiar with how it was transmitted. There were no specific or effective treatments unique to it. There were no known specific preventive steps to be taken. So all of those things had us at the very beginning in a position of a great deal of not knowing about the disease or what we could do. We are in a very different place now. Over the last roughly 15 months, we have learned a great deal about the disease. We now have multiple vaccines that can help to prevent people from getting the most severe harms from the condition. We also know better how to treat the condition. The clinicians can treat it more effectively with better outcomes for the people infected. And we also know with more precision that we can refine or tailor our public health interventions to mitigate the disease in a more tailored and refined manner than we did last year.
And is that why some of the DPH recommendations have gone from broader to more narrow over this course of time?
Yes, our recommendations have evolved substantially. And in fact, they've evolved so substantially that now that we have in Kentucky 55% or so of all adults who have been vaccinated. And we see that even at disease levels that are similar now to what they were last summer, that the number of hospitalizations has not increased to the same amount. That outcomes are better for people who do get COVID than they were before. This has allowed us to lift many of the previous public health interventions we had put in place. And in fact, the governor more recently to announce that most of them will go away during the next few weeks.
From a public health perspective or current DPH perspective, what COVID-19 issues are important to the department right now that you're monitoring specifically?
Well, so we still do track the number of new cases identified. We still do track, the federal government requires hospitals to report the number of people in the hospital, in a regular hospital bed, an ICU, or on a ventilator with COVID, among other data points. We track those types of metrics to help determine how the healthcare system is functioning and what the overall impact is on the population as a whole. We also obviously are particularly focused on increasing vaccination rates. Vaccination is a way to acquire immunity without actually having to acquire the infection, and is felt widely to be a safer route to immunity than actual infection for many people. And so we're focused very much on trying to give people the opportunity to receive vaccination as conveniently and as readily as we're able to.
And what is the most important thing that DPH is looking for into the future?
Well, so obviously what we want to do is minimize the spread of disease and protect people from the worst harms to the fullest extent possible. One of our concerns would be if the disease continues to spread widely and without being mitigated, is that you could have variants or mutations that could form in these viruses, and that those could effectively give the virus, if it's successful, competitive advantage so that it could circumvent the protection that vaccines provide, and we could find ourselves very much in the midst of a serious problem again.
Now, you testified earlier that DPH does coordinate with CDC and other federal partners.
Frequently, yes.
And I assume that's also with vaccines and everything.
Yes.
Based on your knowledge and as your time as commissioner, do you think this type of federal coordination could be done on a local health department level?
This has been in all layers of government response, and each layer has played its roles, and there are certain roles that each layer must play in order for it to be effective. So the national experts have to operate at a very high level by giving general guidance based on general population principles that they then rely on state officials to be able to take those and crosswalk those to the specific statutes and regulations that make each of our states different. And then the local health departments, who are not generally in a position to do the kinds of activities that the state health departments do, are then in an ideal position to apply those regulations or statutes that are created at the state level in their local context, and then to enforce those because they are closer to the actual implementation of the guidance. So it's really required all three layers of government to work in cooperation.
So, in your role as commissioner, do you have the ability to interact with not just CDC, but with the White House task force and the things that are also occurring at the federal level besides CDC?
I do. Yes, I do, and I do regularly.
Now, when it comes to CDC guidance in the public health realm, what is the role of CDC guidance? It's COVID-19.
So CDC guidance serves as expert recommendations, and they generally take a risk-based approach to their guidance, which is useful to those of us who are in state public health, but also challenging at large for individuals to interpret. So using an example in the current restaurant guidance, which I think was most recently updated in December 2020, they will give a paradigm that says low risk, higher risk, higher risk, and highest risk, and there's 4 different levels. A more complex iteration of this, or version of this, was the previous iteration of the K-12 school guidance that the CDC gave, where there were 9 or more different criteria in rows and 5 or so levels of risk across columns. And so if you multiply that, it's like 45 or more different individual boxes. So you have to then apply that into what level of risk will I take in any specific part of activity or what specific metric. And you have to have access to all that data in order to apply the tool. And frequently, the average member of the public doesn't have access to that kind of data. And even at times, it's hard for local health departments to have all that data. So you have to take that complex guidance and translate it into something that individuals in specific settings can actually apply consistent with the context in their state or local community.
That being said, how is the EPA specifically using this guidance? Here, right here, locally here in Kentucky, how are we using it?
Right, so we read documents that were changing often weekly, certainly monthly, and sometimes multiple times a week at the height of this pandemic. We would review those documents, review our guidance, adjust our guidance to tailor it to the specific setting. When there were areas where the CDC guidance was either not sufficiently clear for whatever reason, or where it was difficult to crosswalk it in the most effective way to Kentucky, we would use other approaches, such as I would convene a discussion with the other local health department leaders, and we would dialogue and reach a consensus agreement on how to apply the CDC guidance in the context of Kentucky, and then we would uniformly apply it across the state so that there was consistency for the citizen who was experiencing whatever that situation or circumstance was.
So that's been a state-local collaboration.
Yes.
Does Department of Public Health have data and resources and information that the local health departments don't have?
Yes.
What type?
So we have access to, for example, right now with the vaccination, the federal government has granted direct access to the Tiberius vaccination data system for state health officials and some of our key staff. That access has not been granted lower into local health departments, and it hasn't been granted more widely outside of public health. So we have access to a really important data set that then we have to query and distill from it important information, and then secondarily make that available to local health departments. So we play an important role getting that access for that data and providing it to them so that they can use it for their local decision making. There are other types of data, hospitalization data, that the federal government collects, aggregates, and then we have to then funnel that back out to local health departments.
And just to clear up the report, what is the Tiberius system and what's it used for?
So Tiberius is the name given to the federal data system that tracks nearly everything the federal government has related to the COVID-19 vaccination program.
So based on your experience over the last 14 months, your interaction with these various federal partners, local partners, why do you think, in your experience, that it's important to have a central state agency like the Department of Public Health?
Objection, Your Honor, calls for repeated.
I can rephrase. In your experience, like, we strike that, Your Honor. Has it been helpful to the local health departments to have a central state agency,
Yes.
and why?
So I did testify just shortly ago. This is a disease that didn't exist to span the globe in 2 months. And it took just a couple months to get all the way, literally from the opposite end of the world to the United States. It is certainly reasonable in that context, and we have seen that the disease can spread from Fulton County to Boone County, or from Jefferson County to Pike County, the opposite extremes of the state, in a much shorter time frame. Individuals traverse the counties on a regular basis. I went through 3 or 4 counties today just to come here for this, and on a typical day, I work in 3 or more counties as I span them to get to and from work in my home. In that context, it's really important to try to have consistency and clarity to the fullest extent possible so that the typical citizen in their daily life can have an attempt at clarity and consistency as they go about their daily activities. Otherwise, you would have a very incoherent inconsistent and then there, by extension, ineffectual public health response that the local health departments would have great difficulty applying, and that the individual citizen would have great difficulty following.
What would be some of the issues using the CDC guidance as a 120 county solution?
Well, there be numerous problems. It'd be difficult to use the CDC guidance where each individual county picked their own guidance from it, because then the individual citizen would never know what rules they had to follow as they went from county to county in their regular course of activities. That'd be one thing. Second, the local health departments have been substantially under-resourced for a long period of time and simply do not have staff, the number of staff they need, the types of expertise they need across all of those 61 health departments to be able to review, interpret, and then apply all of those individual guidance documents. They don't have the bandwidth, and so they rely on this larger state health department who has resources in terms of technology and people and certain types of qualified people to do that. And additionally, the local health departments do not have the regulatory authority that has typically resided in the state in order to translate some of these guidances into actual requirements that are then enforceable. So that has resided, that authority at the state level of government. So for at least those three reasons, it's very important that the state plays a coordinating function as it does.
So like the state food code, for example, is a pretty good, I think, would be a good example of that.
Right, your chicken has to be cooked at least to a certain minimum temperature, the same across all of Kentucky. You can't just pick and choose in each different county to cook it to a different temperature.
If DPH couldn't promulgate rules such as I'm using the food code as an example again, how could you enforce anything?
Objection, Your Honor, calls for opinion and speculation.
I can rephrase. What would be the problem in trying to enforce that?
Honor, same objection.
I think that's a factual question based on his experiences that in his current role of what would be the issue, what issues would arise in enforcement if enforcement authority wasn't available. But I can move on. I can move on. I would report.
Okay, it sounds like you are asking for a clarification for sustained objection.
Is there a way that you're aware of at DPH to enforce a CDC rule?
There is no way to directly enforce the CDC rule. The CDC rule has to be reformulated into an order or a regulation or a statute within the state in order to be enforceable within the state.
Have you had the opportunity to review House Bill 1?
I have.
Based upon your observations as the Commissioner of the Department of Public Health, how would House Bill 1 affect the department's ability to address COVID-19?
Your Honor, objection calls for speculation, also probably calls for a legal conclusion.
I can rephrase my question, Your Honor. Are there any issues with House Bill 1 as to the regulatory authority of the Department of Public Health?
Same objection, Your Honor.
Governor, I think the question is that Dr. Stack, obviously, he is in his role as the Director of Public Health. There is a law that's been passed by the General Assembly that directly affects the everyday operations of his division of the Cabinet for Health and Family Services. He's read the bill. I think that he is allowed to discuss how legislation would affect his day-to-day operations of his unit.
Response?
Your Honor, I think we're again speculating about how a bill may or may not be enforced, and I think we are following legal conclusions here and frankly speculation.
Yeah, I believe that he can testify as to how his office would handle it under House Bill 1, so I'm going to overrule the objection.
So, with respect to House Bill 1, House Bill 1 makes a number of changes that directly impact how the Commissioner for Public Health would be able to do his or her job, and how I would have been able to do or not do my job for the duration of this pandemic. Some of the ways, and again, I'm doing this by memory, so I don't have the bill in front of me, but are that it would allow an individual, as I understand it, to select CDC guidance or state guidance, whichever they prefer, and whichever was least restrictive, and use that as their guidance document. Additionally, if memory serves, would allow in one of its sections individuals to rely on a third-party source to find guidance. That could be a State Department for Public Health, the CDC, some other public health body, a trade association, a professional association, a local chamber of commerce. Those are just some of the options that were listed there, I believe, which effectively would outsource the regulatory authority to any source you could find on Google instead of the state government, of whatever branch, just that the state government would not now be promulgating what the rules were that they would follow in the place of business. In my role, and there's also, I believe, it's in House Bill 1, that it says that we are not allowed to enforce the standard. So an individual could pick their own standard from any source, say this is the standard they would follow, and then even if they fail to follow the standard they themselves picked, the state would have no ability to enforce their non-compliance with the standard that they themselves picked. Effectively, having gone through the last 15 months of this pandemic, it would render me powerless to promulgate regulations or orders for the safety of the public health in a consistent, uniform manner across the 120 counties of the Commonwealth. Apply them with an expectation that enforcement was an option for non-compliance, and to take steps like that to help protect public safety and health.
If that bill was to go into effect, how would that affect your day-to-day priorities and activities as Department of Health? Let's be as the Commissioner of the Department of Public Health.
I think, again, there's multiple bills that were passed that overlap a little bit, but can I ask a clarifying question? Is this the bill that includes the language about it can only promulgate an executive order for a 30-day period?
That's Senate Bill 2. We'll talk about that in a minute. Let me rephrase my question to kind of clear that up. If the Department of Public Health was trying to enforce House Bill 1, how would you have to delineate your all's activities, your priorities? Where would all that fall?
I don't know effectively under House Bill 1 that we have any enforcement authority. I don't, because an individual could pick, it really ultimately would be, I did study classics, so I use this in the classical sense. An extreme case of caveat emptor would have to be the individual would have to review, because literally in that bill it says you have to affix to the door of the business, the entry of the business, this plan. Any individual citizen entering a place of business would then bear the sole burden of him or herself to read what was affixed to the door, determine if they felt that public health guidance was sufficient, and then I guess determine if the individuals who are conducting that place of business were complying with that guidance. And they would have to do that every place they went into, or disregard and have no assurance whatsoever that any measures were taken. So that is very, very different from what we have done so far, and what states around the United States have done, which is to take CDC guidance, which rapidly evolved in the face of a growing body of experience and knowledge, apply those in a state-specific setting, create orders and regulations that were consistent across the state, and enforce those across the state to the extent they're able to.
If that went into place, would DPH be able to assist local health departments in enforcing this?
I don't think we'd have much of it wouldn't be very effective in their enforcement. We could certainly try to be a resource to educate, to inform, to be a source of information. but I don't know what lever we would have to enforce from the state level. And the local health departments rely upon the regulations we have. For example, my department has a role in pool safety. There are regulations for pools. The regulations are uniform across the state. The local health department and their inspectors use the state rules and apply those when they do the inspections. So I think it would remove that whole layer of the state promulgating those rules and those requirements, and it would leave the local health departments in an untenable situation where they didn't have such guidance that they could enforce. Therefore, I don't know what they would enforce.
So that would create a void.
Substantial.
At our state, moving on, you kind of gave a sneak preview. Have you reviewed Senate Bill 2 in your official capacity?
I have.
And based upon your reading of Senate Bill 2, how would that affect your ability to do your job as Department of Public Health Commissioner?
So if memory serves, Senate Bill 2 would only permit us to promulgate an emergency order or reg for a 30-day period, at the end of which the order would sunset unless we obtain the approval of the legislature to sustain it or continue it. We are now, I think, we're about 15 months into a global pandemic. Where clearly it is extended well beyond 30 days. And it would require, unless the State Department for Public Health had no role to play past 30 days in any public health emergency, it would require immediate, often daily access to a legislative body in order to regularly present and attempt to persuade to certain courses of action. And so it would render powerless the State Department for Public Health in its role to try to protect for the fast evolving infectious disease threat we have just kind of are beginning to emerge from.
No. There's no time on these viruses. They don't start in 30 days, do they?
They do not. And in fact, as we sit here today, India has close to 300,000 new cases a day and staggering death toll. So even though we enjoy this relative calm in the United States at present, there is still a global crisis unfolding.
Would this restriction, this provision of Senate Bill 2 be particularly difficult in regard to quarantine?
Yes, it specifically removes language, as I recall, about isolation and quarantine. Now, I'd observe these are principles about government's role in isolation and quarantine that have been written about for centuries or millennia. These are well-established interventions that authorities take to try to mitigate against the spread of dangerous communicable disease. And so that law, as currently written, precludes, or at least strikes out from law, our ability to isolate and quarantine people in the middle of an infectious disease threat.
And based upon what you know in your role as commissioner, what would the impact of Senate Bill 2 be on existing public health orders and regulations?
That as soon as the force of those laws is allowed to take effect within 30 days, all of the executive orders related to the state of emergency would go away.
That's all the questions I have.
Council,
Yes. Doctor, you still have an exhibit book in front of you. Excellent. I wanted to begin with the array of horribles about the recent legislation. I'm going to put the actual text of the bills in front of you. If you go back to exhibit 24, they are tab 24A through D, and we're just going to kind of look at them one at a time to begin with. Let's look at House Bill 1 first. That's 24A. Do you see that in front of you? To be clear, Doctor, this bill says that notwithstanding any state law, administrative regulation, executive order, or executive directive to the contrary in Section 1,
during the current state of emergency declared by the governor in response to COVID-19 or any future state of emergency related to any virus or disease, including but not limited to any mutated strain of the current COVID-19 virus until January 31st, 2022, any business, for-profit or not-for-profit organization, local government, association, or school district, public, private, or religiously affiliated, may remain open and fully operational for in-person services so long as it adopts an operating plan, right? And there's some requirements for that operating plan. One, it has to meet or exceed all applicable guidance issued by the Centers for Disease Control and Prevention or by the executive branch, whichever is least restrictive, right? And then it also has to detail how the business, for-profit or not-for-profit organization, local government, association, or school district, whether public, private, or religiously affiliated, will foster the safety of employees, customers, attendees, and patrons, including social distancing requirements, and is posted in a conspicuous place on the main entrance door of the physical location of the business, for-profit or not-for-profit organization, local government, association, or school district. I believe it also says, and on the website, right, of the business?
Yes.
Okay, so Doctor, a minute ago you said people just can go out and Google and do whatever they want, right?
Yes.
That's not true because it has to meet or exceed all applicable guidance issued by the Centers for Disease Control and Prevention or by the executive branch, whichever is least restrictive. Correct?
Please restate that question.
Right. I mean, the doctor said people can just go out and Google and do whatever they want, and I said that's not true because the plan has to meet or exceed all applicable guidance issued by the Centers for Disease Control and Prevention or by the executive branch, whichever is least restrictive.
And I have to object to that question, or that calls for legal conclusion.
Your Honor, they just got into the parade of terribles about how his business or how his department is going to run afoul of everything in the world if this bill is enforced. And the doctor made conclusions about this particular statute that are actually have no basis in fact in the plain text of the statute. So I think it's fair
I
cross.
believe the doctor testified as to all of that when I overruled the objection and allowed that testimony to come in as to how they would handle it. He was testifying as to what was in the bill. That testimony stands, it's on cross-examination.
So Doctor, the plan that has to be adopted by the business, let's just say business, I realize it's public, privately, there's other options, but let's just use business. It has to meet or exceed all applicable guidance issued by the Centers for Disease Control and Prevention or by the executive branch, whichever is least restrictive, right?
No. Do all sections of the law apply?
Well, sir, there's an and between 1, 2, and 3, so yes, it has to meet all of those.
In 3B, the business, for-profit or not-for-profit, local government, association, or school district, whether public, private, or religiously affiliated, may prepare the plan detailed in paragraph A of this subsection itself, or may utilize a plan prepared by a local or state government agency, local or state chamber of commerce, trade association, or other recognized affiliated organization.
That's true, and that plan that the affiliate organization has to adopt still has to meet the requirements in 1A, correct?
The least restrictive element of that.
Right, it has to meet or exceed all applicable guidance issued by the CDC or executive branch is the first premise, correct?
That's what that says there.
And then it has to detail how the business is going to will foster the safety of employees, customers, attendees, and patrons, correct?
Yes.
Now, when we look at the enforcement option, and we look at subsection C, which deals with the enforcement option, it says no state or local agency shall enforce restrictions related to the state of emergency impacting the ability of the entities listed in the subsection to remain open and fully operational for in-person services that exceed current applicable guidance issued by the Centers for Disease Control and Prevention or the executive branch, whichever is least restrictive, correct?
That's what the language says.
Right, and so you are able to fully enforce against any entity that is not in compliance with either the executive branch guidance at the time or the CDC guidance, correct?
No.
That's what it says.
That's not the effect of it.
So you're saying that what the legislature put down in writing there isn't the effect of it?
No.
Okay. I mean, you would agree with me that if somebody has a CDC plan or an executive branch plan, you can't enforce it, but why would you not, if they didn't have either one of those, be able to enforce?
Does it require one to understand the CDC guidance in order to interpret it properly and then create an appropriate plan?
The doctor has to meet or exceed all applicable guidance, correct?
Who determines that?
You're the enforcement authority, correct?
I have no enforcement authority except to enforce what they have selected.
Well, that's your opinion, isn't it? I think you talked about Senate bill, was it Senate bill? One, it was Senate bill 1 that dealt with the 30 days, correct?
Yeah, I think it was Senate Bill 1, the Senate Bill 1 and 2, I did.
Okay.
I don't know if it was 2 or 1.
And Doctor, when it comes to,
Clarify, it was two. Sorry.
oh, was he not talking about Senate bill 1?
It was two.
Okay, let's look at Senate bill 2. Let's look at, I believe, Senate bill 2 is going to be 24C. And Doctor, I've got a couple of provisions that are not necessarily relevant. I think the portion you were looking at starts on page back to section 22 at page 57. That amends chapter 214. Was that I think that was the section you were talking about.
So I'm looking right here at 24C, is that where you want?
Yes, sir, 24C. Go back to page, it says page 57 and 59. I did not, this was a very large bill and not all of it's applicable. And so I just took the parts that I thought we were fighting about.
Oh,
And you were correct.
What's that? Yeah. So page 57, Doctor, it says 57, 59. Tell me when you're there. It's at the
yeah,
bottom.
I'm on it now. I had to go forward, not backwards. So I
Okay.
think it was 57.
This amends chapter 214.020, correct?
I see that in line.
Right. And if you look at it, I think the subsection 2 that begins there says an administrative regulation promulgated under the authority of this section shall, and it's got some language in it, right, about being in effect no longer than 30 days if the administrative regulation does certain things, including placing restrictions on the in-person meeting or functioning of businesses, right?
Yes.
And it says it has to include the penalty, appeal, and due process rights for violations, correct?
I see that.
And it has to contain the public hearing and written comment period, correct?
I see that.
Doctor, there's nothing in this provision that would, and I've looked, that would prohibit or restrain your ability to impose isolation or quarantine, correct?
There is one of these 3 laws where they strike specifically out.
Well, they did at the bottom of page 57, but they also allow you to broadly promulgate administrative regulations under KRS Chapter 13A to prevent the introduction or spread of such infectious or contagious disease or diseases within the state, correct? That still is allowed. That's on page 57.
Subject to the limitations on page 7.
You mean on page 58?
Well, page 7 and 59.
Okay,
Is right after
okay.
the 24C.
Right, and all this is that the regulation in question is in effect for 30 days, correct?
After which we can't re-promulgate it for a period of 270 days.
Doctor, that's true. You can't promulgate the exact same regulation with the exact same language, correct?
I believe it also says they're functionally similar. That doesn't say functionally similar here, it says that it can't even be of similar nature.
Are you, where do you see that?
There's 3 different laws.
I would have just said it. Did the plan get wrong?
Must be any other bill.
Which bill do you think it's in?
Let's go look at some.
Senate Bill 1.
You've got the whole text here, but not all of this applies to college. Applies to.
Oh, Senate Bill 2, other than the 214 section, was a massive overhaul of the regulation promulgation procedures.
Well, just for the benefit of the record for clarity here, so on page 4 of 20 in Senate Bill 1, it's where it says upon expiration of an executive order or other directive describing subsections to it, which is similar language to what's in Senate Bill 2. It says that the governor shall not declare a new emergency or continue to implement any of the powers in this chapter based upon the same or substantially similar facts and circumstances as the original declaration or implementation. So,
Well, Doctor, that's true for Chapter 39A, correct?
and
So Chapter 14 is a separate source of power for the Department of Health, correct?
I'll defer to you because I'm not here to render legal opinion.
Okay, I want to talk about the issuance and the reissuance of regulations throughout this pandemic because, and let's go take a quick look at Exhibit 11 with me, if you don't mind. You there? This is the regulation that the department issued, I believe, on January 5th, 2021, related to face coverings and face masks, correct?
Yes, it is about basement.
Yeah, it's on the very first page, there's an effective date on there. Doctor, you would agree with me that, in fact, this regulation in question was promulgated and repromulgated regarding the same subject matter throughout the pandemic, correct?
Yes, but it's been modified over the course.
Right. Right, you guys have added exceptions and removed exceptions to the face coverings, correct?
Yes, over the course of the
And in terms of isolation and quarantines, if you were to issue regulations under Chapter 214 every 30 days, you would be able to do the same thing with those, correct?
I want to object to that question. Once again, it calls for a legal conclusion.
Your Honor, this is, I think it's one of those, we're already down this road because he's talked about how he can't do his job anymore. And I'm honestly his cross. And so I think,
Given the testimony, I think that is where we're at. So.
What's the way he rolls?
Any question you're waiting for me to respond?
right. The question was, in terms of isolation and quarantine and other requirements under Senate Bill 2, you would be able to issue and reissue, with changes, regulations related to isolation, control measures, et cetera, correct?
I'm having a difficulty here is the interplay between row 11 and 12. The limitation. Is a interplay with the comply with an executive order issued KRS Chapter 39A. Because there has been a declared state of emergency, and we have relied upon that in order to do these interventions. And so the interplay between these, we use executive orders, we use emergency regulations, and the complexity of where all those interweave and where Senate Bill 1 and Senate Bill 2 do actually overlay, it is a complexity that I'm conceding, and that's what I can tell you is that it is my looking at what is here in Senate Bill 2, that we can promulgate only for 30 days, that if we were to go past 30 days, we have to get the legislature's concurrence to repromulgate those things if they go on further. And if we were to have to do that, then I have to have access to the legislature to be able to go over and get their concurrence.
Well, that's one option, Doctor. Is there any reason as you sit here right now that you would not, and maybe the answer is you're not a lawyer, you would want to defer to a lawyer, but that you would not be able to simply repromulgate regulations every 30 days?
No, I want to object. I think it's misrepresenting the state or the regulation of the bill to our staff.
Your Honor, we completely disagree with that. And obviously, the mask mandate in the regulation that Exhibit 11 is an example of them doing just that. Issuing a regulation, reissuing a regulation. We think that power continues. I mean, they can't use 39A, they can use 214, and we think Senate Bill 2 allows them to do exactly that. It just has to be done every 30 days.
Did you have more, Council?
I have more caution, but I was on here.
Did you have more to your argument, Council?
Once again, I think that's a misrepresentation of the laws. Like we said, we're fighting here today. He talks about the emergency regulation process, but there's limitations on 270 days there as well. So I just think this is a misrepresentation of what Senate Bill 1 and 2 do in regard to the reg process.
Apparently, there's disagreement among council as to the distinction of how the law applies to issuing regulations and to executive orders. So the way I think I is sitting here now, given the witness that testified as the limitations he has under these laws, in fairness to a lot cross, I think the best way to clear that up is I'm going to allow you to proceed. You can address it on redirect, but I do hope that we don't have to tie this up too long on these issues, because we're getting into questions of how the bills read. And I think those are questions of law, even though I did allow the witness to testify as to his limitations, that's what we use right to cross. It's a long-winded way of saying that.
Point taken. Dr. Speck, if you don't mind, tab back to Exhibit 6-1.
That's 6.
Exhibit 6. Exhibit 6.
Healthy work.
Doctor, this is the healthy at work minimum requirements that are still in effect and was effective April 19, 2021. Fair?
Correct.
I think some of your testimony was that the CDC guidance, the public is not in a position to discern that, to distill it down, and be able to make decisions based off of it. Did I summarize your testimony accurately?
And that is a challenge to get.
Okay. Doctor, I'd like you to, if you can look at page 2 of that exhibit. And just to be clear, Doctor, this particular Healthy at Work guidance, this was something that you and Secretary Friedlander issued, correct?
I suspect it was, just with the signatories on the different things are relying on the legal team. But
Sure. Doctor, do you see under number 7, sanitation? And I'm going to read this to you. Entities must routinely and consistently sanitize high contact surfaces and areas, e.g. doorknobs, equipment, workstations, and restrooms in accordance with CDC guidance, correct? And so, Doctor, you yourself are referencing the CDC guidance in your own regulations and yet criticizing the General Assembly for doing the same thing, correct?
it's incorrect by lacking context. And I'll expound on that. There are numerous other sections in this guidance where we are very explicit on what the requirements are. We have reviewed extensive CDC guidance, and in this context have chosen that that particular guidance is discrete enough, usable enough, and applicable enough that we referenced it as a good resource for the public. But we don't reference the CDC guidance in many of these other areas, and in fact, in the physical distancing requirement and facial requirements, we explicitly describe what must be done or refer to a state-level executive order that gives that clarity. So yeah, I don't find those inconsistent. We recognize the CDC as an expert body providing useful guidance. It's just that we have helped to place it in the context so that people in Kentucky can use it effectively and most consistently.
Paragraph 8, daily temperature/health checks, the last sentence of that first paragraph, entities should refer to CDC guidance on how to conduct temperature and health checks, correct?
Yes.
Same thing there, the CDC is okay to rely on in that context.
Same argument that I just conveyed.
Doctor, I'm going to go back to Exhibit 4. You look at Exhibit 4. This is the CDC guidance for restaurants and bar operators, correct? One of the things it says is that, and I'm looking at the second sentence in, restaurants and bars can determine, in collaboration with state, local, territorial, or tribal health officials, whether and how to implement these considerations, making adjustments to meet the needs and circumstances of the local community. See that?
I believe I
So the CDC, at least, is looking at this guidance and suggesting that restaurant and bar owners can read it, understand it, and implement it. There?
No.
That's not what it says?
Elsewhere in this same guidance specifically says that these have to be applied in the context of state and local laws and regulations.
Right, it talks, the next sentence, I think, is what you're referring to. These considerations are meant to supplement, not replace any state, local, territorial, or tribal health and safety laws, rules, and regulations with which businesses must comply. Is that what you're talking about?
Right, so that when the CDC promulgates these, they acknowledge and recognize, and that's the context within which they promulgate them, and the states will then apply them in more discrete language. In your Exhibit 7 is our most recent Healthy at Work supplement for bars and restaurants, where there's much more explicit direction in a number of areas.
And in two places there, within that, you thought it was appropriate to reference and incorporate the CDC guidance, correct? We just talked about it, the temperature checks.
Well, that was minimum requirements. I'm talking specifically about Exhibit 7, which is our supplement requirements for bars and restaurants.
So, Doctor, the minimum requirements apply to every single business and entity within the Commonwealth, correct? Okay. And so, at least for temperature checks and sanitation, you believed it was appropriate to incorporate the CDC guidance, correct?
For those two things, yes.
And the General Assembly believed it was generally appropriate to incorporate the CDC guidance. Fair? In House Bill 1.
Mr. Wiest, I'm not trying to be difficult here with you, but that's not fair because the legislature has determined to outsource entirely to the CDC guidance documents for the individual business operator to reference those, review them, interpret them, and then apply them. That's not what we've done in these documents. We have done that. We've reviewed them, interpreted them, and placed them in context so that the business owner references a specific guidance for a specific purpose. So it's not the same as what the legislature is.
Said another way, you believe that you're in a position to decide what CDC guidance applies, and the legislature is not in that same position. Is that fair?
Again, not necessarily. I'm not opining on what is the role of the legislature and what its authorities are distinct from the executive branch in that context. But as far as state governments armed for giving public health guidance, that's generally resided within the Kentucky Department for Public Health.
Doctor, let me ask, the food code in Kentucky you referenced with Mr. Duke. Remember that just a couple minutes ago?
Chicken temperature, if you're.
Chicken temperature. The food code references the federal food code and incorporates it by reference, does it not?
I'm not prepared here today. I don't know.
Okay. Are you familiar with any other Kentucky enactments within Kentucky law that incorporates federal guidance within it?
I have been pretty consumed this year with COVID, and I don't know what other specific ones. If you showed me examples, then I can observe.
Doctor, if you can look back at Exhibit 3 real quick. One of the things I think you testified to was that it would be really difficult to enforce House Bill 1, right?
Yes.
Doctor, this is the plan for Beans and Mr. Hayhoe that he prepared. You would agree with me that an inspector from a health department could look on a company's website or a company's door and see if there is in fact a plan, correct?
They should be able to physically observe if there's a plan on the door. Yes.
Is there any problem with enforcing that aspect of the law in terms of whether or not there's a plan?
I won't accede to your absolutes, but I'll say it should generally be doable. So.
And there's other public health contexts in which entities have to prepare plans for some things, correct?
Suspect there are.
Okay. And the government's able to enforce those things, right?
I can't accede to that either, because if an individual has determined their own standards and applied them, generally no, the government wouldn't come in and apply someone else's self-imposed standards.
Okay. Doctor, I think you previously testified in this matter that yourself, the governor, and Secretary Freeland have been, quote, promulgating rules of breathtaking scope and implications since the pandemic began, correct?
You like that quote. You've used it a number of times, Mr. Wiest. Thank you. So flattery is, their imitation is the sincerest form of flattery. I appreciate that. But in a once-in-a-century pandemic, the likes of which the human species had not seen since the 1918 influenza epidemic, yes, I think it's fair to say we faced a breathtaking crisis with breathtaking interventions.
And Doctor, presently, the mask mandate and the other healthy at work requirements that we just looked at, they're still in force, correct?
The newest, the April ones.
Yes, sir. And there's still enforcement going on for violations of those requirements, correct?
Yeah, specific, but a lot of it has now become guidance and not as much of it is musts. And
So for the musts and the shalls, the actual requirements, there's still enforcement going on of those requirements,
I
correct?
suspect there is.
Dr., back to the CDC guidance for restaurants and bars, that has not changed since December of 2020, correct?
When I looked, the most recent one I saw was December 2020. But it's been the same.
And that's the version that's the guidance in version 2,
It's the
correct?
one you have at this moment.
I think we confirmed this in prior testimony, but coronavirus doesn't care if people, if a group of people are sitting next to each other in a restaurant or an office conference room if they're engaged in the same activity, correct?
Agnostic to the purpose.
Okay. And I think we talked about this in July as well, but I just wanted to confirm it. In a normal conversation, respiratory droplets, at least at the time your testimony was respiratory droplets, could remain suspended in the air for approximately 3 feet, right?
Now I have to actually see my testimony, but
Yep.
we can read it.
I don't know if you guys have the transcript from the July hearing, it's page 479. I'm happy to put the mask back on. I will tell you that I've been vaccinated to the extent that raised concerns. 479.
So the court requires a mask, not the current executive order. Too.
Typically, it's thought, at least based on some research done in the past, that in a normal conversation, respiratory droplets may remain suspended in the air for approximately 3 feet, right? Yeah, that's what I said based on my understanding. Yeah.
That is my
Your Honor, object, I don't think to refresh his recollection, he just had it read, he just read it to the record and he confirmed it.
Your Honor, I'm not required to refresh, it's cross.
What's the basis of the objection?
So, Your Honor, I don't think Mr. Wiest properly refreshed the witness's recollection. The witness said he didn't remember. He attempted to do so. It doesn't mean he still can, but he didn't do it right at that time.
Your Honor, it is cross, and if he says he doesn't remember, I'm allowed to cross him on it.
I believe the relating to the repression of witness's testimony does correct. This is cross-examination. We also dispute that this testimony is breaching the service of the court.
Doctor, there's no absolute ability to eliminate the risk of infection other than to lock everyone down in complete isolation for 14 days, correct?
Are you reading my testimony to me again?
Yes, sir.
Yeah, so my one qualification would be the last time we did this, Mr. Wiest, that when additional context was provided in the words before and after, it changed entirely the meaning. So, if you could repeat that again, I'll give you a response.
Sure, there's no absolute ability to eliminate the risk of infection from COVID other than to lock everyone down in complete isolation for 14 days, correct?
Yeah, I could repeat that here today and I would feel comfortable.
Doctor, for restaurants, I think we just looked at that guidance. You do permit plexiglass barriers between seating, correct?
For booth seating.
And booth seating, and in that instance, people are closer than 6 feet, correct?
That's correct.
And I think your testimony back then was that there was less risk if people were seated back to back versus face to face, correct?
Correct.
And I think you acknowledged that we primarily project towards others we face, correct?
Mr. Wiest, I'm not objecting. Just please would you reference the page and I can at least try to keep up.
Yeah, I'm on 498 and 499.
As you go through the quotes.
Okay. And Doctor, your primary concern with not allowing seating to be 3 feet apart was concern people might get up and move, correct?
So you're going to show me my testimony. I think in the context we had that discussion, people seated, not in blue seating, not with their backs faced, joining back to each other in different directions and closer, have the opportunity to project and aerosolize and spread droplets in a multidimensional way, which is not the same as two people sitting back to back with a plexiglass barrier between them. So, and what I also acknowledged in some language in there, in that transcript, was that I acknowledged the limitations of the guidance and that we were trying to do the best we could to allow business owners to operate in a risk-reductive manner, but not a complete risk-eliminating manner.
Sir, I'm on page 500. Your testimony in July was that, quote, that if you and I are sitting back to back, 3 feet apart, that, quote, there is probably not much more elevated risk, even if it is an elevated risk, from having a plexiglass barrier between 2 people at a booth, correct?
I have to see it.
Okay. Your Honor, may I approach you?
Saying the words above and below it this time. I got it. Yeah, no, I don't. There's more words above and below it this time. Okay, okay.
So Doctor, again, if you and I are sitting back to back, 3 feet apart, there's probably not much more elevated risk, if there even is an elevated risk, from having a plexiglass barrier between 2 people at a booth, correct?
That's what my transcript says there.
And that was your testimony then?
Yes.
Have you learned anything that would change that?
The point that I made there was that you have to read the plain language interpretation of that. People are sitting back to back, facing complete opposite directions. That, yeah, the plexiglass barrier probably doesn't add a lot more to it. But it was in the context, I believe, of open seating in a restaurant where people generally don't sit straight back to back facing complete opposite directions. That's the context in which the extended discussion happened. But yeah, so that statement, as I made it there, I think for what I knew at the time, I believe was true then.
Doctor, in terms of the hours of operation restriction for restaurants, do you have any evidence that you can point to that COVID-19 presents more risk at 1:01 a.m. versus 1 a.m.?
It's not the time, it's the behaviors that ensue the later you go in the evening in those settings.
Okay. And so for a restaurant like Bean's that does not serve alcohol, what behaviors are going on at 1:01 a.m. versus 1 a.m.?
So the guidance are for bars and restaurants or dining establishments. And so when led to that level of guidance in bars and restaurants, the behavior that goes on at 1 in the evening is very different a lot of times than happens at 5 because people have been drinking and engaging in social activity at different times.
Your testimony in July 2020 and this was in response to a question Mr. Duke, 514, 515, was that we could exit the emergency without a vaccine, correct?
You have to show me that. Australia and New Zealand have shown that you can control the disease effectively if you follow all these other measures without a vaccine. But you can see the context.
Yeah, I'm happy to show it to you.
It's only my admiration for your skills, Mr. Wiest, that requires me to read the full language.
Okay, this was in response. Sure. This was your question and answer.
Sure. Sorry about the question. But those mitigation strategies, that question.
Yep. Great. So, Doctor, again, the testimony back in July 2020 was that we could exit the emergency without a vaccine, correct?
If we follow those mitigation strategies, yes.
And we obviously have not been able to exit the emergency without a vaccine, correct?
But there hasn't been complete adherence with mitigation strategies.
Doctor, since December 2020, Kentucky and other states began rolling out vaccines for COVID-19, correct?
Yes.
And you would agree with me that the vaccines, all evidence today shows that they're effective, correct?
Yes.
You would agree with me that all studies to date reveal that the vaccines are also effective against the mutation, at least so far, correct?
Mostly effective, yes.
Okay. I think you would agree with me, the messenger RNA vaccines in particular is amazing, cutting edge technology, correct?
Yes.
Some studies, I think, Doctor, I was on the Kentucky Public Health website yesterday, and it revealed that there were only 2 deaths out of, I I think 69,168 cases from ages 1 to 19. Does that sound about right from COVID-19?
I don't know that off the top of my head, but the death rate is substantially lower in the younger cohort, yes.
Okay. And in terms of death and the age of decedents from COVID-19, you would agree with me that the 74.6% of deaths have been in those age 70 and older, correct?
There's a strong age-related association with mortality, yes.
In fact, 91.5% of the deaths have been age 60 or older, correct?
That's consistent with my understanding.
And for that reason, I think,
In Kentucky, I should just qualify in Kentucky.
right, and I think for that reason, when the vaccine was scarce, DPH prioritized our older population for vaccines, right?
Correct.
As of yesterday, I saw 1,908,850 people were vaccinated in Kentucky from the Department of Public Health staff. Does that sound about right? Okay. As it turns out, I think that was about 54% of the state that's 18 and over, right?
Approximately right.
And in addition, I think 554,194 over the age of 65 have received the vaccines, correct?
Everything you said in this immediate questioning has been okay so far, so I'll say yes.
And that, from your dashboard, showed that about 80% of the population over 65 has been vaccinated, correct?
Yes.
Doctor, let me ask this question. As you're aware, we are near here to the Ohio border, right, in northern Kentucky. Is DPH tracking Kentucky residents who are going over to Ohio or neighboring states that receive the vaccine?
We do check on a periodic basis the people who are Kentucky residents vaccinated outside of Kentucky and other state residents vaccinated in Kentucky. But because of the limitations of data tracking, we know the absolute numbers when we look, but we don't know the specific.
So I guess here's my question. I went over to Ohio to get the Pfizer series in I think March or April, and is that going to track as part of the numbers that you're reporting on your website or your dashboard?
Yeah, so my recollection is from about 2 weeks ago, but there were approximately 13,000 more Kentucky residents vaccinated with their first dose outside of Kentucky than there were out-of-state residents vaccinated inside Kentucky. 13,000 out of, at that time, about 1.8 million. So as far as is there a material difference, it's a pretty small difference when you look at that info.
So my question is, what are you reporting though? The people that have gotten it in Kentucky, or are you reporting the number of Kentucky residents?
I'd like to object to this entire line of questioning. The purpose of this hearing here today is the applicability of 3 specific pieces of legislation focusing on mitigation and those efforts. The vaccine effort is not part of this hearing today. It's, in my opinion, it's totally separate, and this line of questioning is improper.
Your Honor, we are here in part. The defendants have argued that they have to continue their mandates, law notwithstanding. And there's a terrible public harm that's going to befall the Commonwealth as a result of it. And if large percentages of people are vaccinated, obviously, I don't think that's true. And I think this goes in part to the equities in this case, the number of vaccinations that Kentucky residents have received.
I was briefly in response, I don't, as far as the number, we keep daily updates that are for the public on the number of Kentuckians that are vaccinated. And I don't think that number's in dispute. I don't see where this line of questioning, once again, is relevant to this proceeding here today, because those numbers are updated, they're available. The court can take judicial notice of them with their record on the website, and you can do with that what you want to. But this line of questioning is not going to change the fact that that's what our data is showing, and that's what our data is reporting, and that is updated every single day, even on the weekends.
This case primarily turns on whether or not there's a different posture because of the General Assembly's activity. I don't see how it turns on how many vaccinations were engaged in or not, and I think that we can assume for purposes of that consideration that the vaccine is going to do what you're purporting it to do. And I don't know that any of that has been demonstrated, whether or not even the vaccine manufacturers have, I don't know, maybe the testimony can bear that out, or maybe not, that it would prevent recurrences of the disease or whether it just minimizes symptoms, I don't know. If there's a need to get into all that, perhaps we can get into all that, but I do think council's objection is likely to be sustained unless you know why it has a bearing on those laws that were passed on General Assembly.
Your Honor, I think in part, the availability of the vaccine drove those laws by the General Assembly. The availability of the vaccine goes to the public harm, which is, if the Moffin factors apply in permanent injunction, I don't know if they do. There's no case law that suggests they do, if they do. And I think the availability of a vaccine goes to the harm of lifting the mandate, so to speak, or the lack thereof.
Well, unless the text of the law that was passed by the General Assembly states it's based on vaccine. And if it does so state, then I think the question is one of the context and the text of the bill, not what was in the minds of the General Assembly. I don't know that it would matter what's in the mind of the executive unless it turns on the question, and I don't see that it does, so I'm going to sustain the objection.
Dr. Steck, would you agree with me that we're at the point where virtually every adult over the age of 18 has had the opportunity to receive the vaccine and wants it?
I'll agree substantively that, yeah, I think adults now have access. If they want to get vaccinated, they have opportunity to get vaccinated, yes.
Okay. Let me ask, existing evidence to date, does it show that the vaccine prevents recurrence or suppresses symptoms, or both?
Those are pretty substantive discussions in and of themselves. It clearly decreases disease severity. It also appears likely to decrease the likelihood of becoming infected. There are some breakthrough cases, but they are felt to be a very small percentage of the whole that's vaccinated.
Doctor, we previously have talked about a cost-benefit analysis that you and others have engaged in weighing public health interventions, correct?
We've had a discussion along those lines, yes.
And I think you've used the term, you recognize the consequences of government mandates, correct?
There are consequences to every choice, yes.
And those consequences extend beyond simply reducing COVID cases and deaths, correct?
They do.
Do you agree that reasonable people can come to a different conclusion in terms of the weighing of those costs and benefits?
Yes.
Doctor, I'd like you to look at Exhibit 25D. It's the release, I think the governor issued last week, May 14th. Let me when you're there.
Okay.
Have you seen this before?
Not in this form, yes. So the subject.
Do you agree with the governor's data that total cases have declined 18% over March and April?
I'm going to defer to that because my team helped put that together, but yes.
And do you agree that hospitalizations have declined 19% over March and April?
Yes.
And do you agree that deaths have declined 48% over March and April?
Yes.
As a consequence of those factors, the governor is proposing lifting the mandates on June 11th, correct?
Yes.
One second. I tender the witness to the Attorney General's office. You need to vote.
You have to see your witness.
Thank you, Your Honor. Good afternoon, Dr. Stack. I'm Vic Maddox. We've met at least virtually before. I want to ask you a few other questions. I'm going to try to be very brief. First of all, have you ever, are you board certified in anything?
Emergency medicine,
Okay, so about 15 months ago, you were an emergency room doctor, is that right?
just practicing emergency medicine.
Okay. Have you ever practiced public health?
It depends how you define that. So in my previous leadership role as an elected leader for the American Medical Association, we did a number of public health things, specifically to improve the health of the nation. So I have not practiced public health as a state health commissioner, but I was engaged in the promulgation of those.
So you were president of the American Medical Association, right?
Correct.
Is that a largely a political position, or is that a scientific or medical position?
I object to form the question, Your Honor. It's all speculation.
I'm just asking you, Ron.
It's a medical professional association.
Okay, professional association, right? Are you board certified in epidemiology? Have you ever practiced epidemiology? As a researcher, as a professor, as any sort of professional holding yourself out as an epidemiologist?
Not in the context you're asking.
Okay. Do you have any practice experience in family health? Family doctor?
Emergency medicine serves as a substitute for a lot of primary care, and so I have extensive experience with primary care.
In February, in the Franklin Circuit Court case, I asked you what conditions would have to be in place to determine if the emergency should end, the state of emergency should end. And you said you couldn't offer an opinion on that, and then I asked you if we had to be at a state where there were 0 cases, and you said no. Do you remember that?
I do.
Okay. And then you said, but we do have to get to a place where the United States of America, and I mean, counselor, here's the challenge with the way you were asking the question. I wondered if you could finish that statement, where the United States of America. What position or state of affairs do we have to be in for this emergency to end?
Does the United States of America add any relevance to the question? Or are you asking me just again more simply, what conditions would have to be satisfied before?
That's fine. Yeah, I'll ask you that question. What conditions need to be satisfied for the emergency to end? And I ask you this in your capacity as the Commissioner of Public Health, who I assume advises Governor Beshear on this question. When does the emergency end, right?
Yes.
Okay.
And so I take it as a fair question. So I am one of multiple advisors across a lot of domains. And so from a public health standpoint, we would want to make sure that were the disease to escalate, that healthcare capacity would be sufficient to provide adequate care to people, both with COVID and with other conditions that were not COVID related. That was a big worry in the early part of the crisis. We also would want to feel confident that people had an opportunity to get an intervention that could keep them reasonably safe from everybody else's general activities. In this case, the problem with COVID earlier in this journey was there was no tool, there was no intervention you could take to keep. So if you lived in a nursing home, and if a single person with COVID came into the nursing home, they could kill half the nursing home by spreading that disease. The residents of that nursing home would be subject to the harm of someone else's actions. The vaccines have changed that substantially because now people who choose to get vaccinated can mitigate much of that harm. So from a public health standpoint, the fact that the vaccines have now, with enough time, shown themselves to be very effective, that you can choose to get vaccinated and mitigate the worst of the harms. Not all of them, but the worst of the harms. You can't eliminate all the risk, but you can reduce it to a level that is more tolerable. Those kind of things from a public health standpoint lead towards an eventual easing of restrictions. And then when you ask me, well, so when would a state of emergency be ended? That would have to be a decision our governor has to make, not a health commissioner, because there's a whole lot of ongoing relief work that's being done, not just in public health, but across other branches of government. And those authorities, in order to use federal resources and provide them to the citizens of Kentucky, is a multidimensional decision. So that decision about when the emergency ends best resides with the governor, who has a portfolio of advisors across a lot broader territory than just public health.
But as the public health advisor, what is your best advice for when the emergency should end?
Well, it's just that complicated, like I said, from a loss of human life or a human harm situation. The vaccines would seem to suggest that the public health part of the crisis is beginning to abate in the nation. But that's not the same thing as the other support we still have to provide people as we finish out the end of the year.
Are you aware, I didn't mean to interrupt you. Okay. Are you aware, Doctor, of the degree to which the governor's office has considered the secondary effects of the lockdowns, such as the increase in opioid deaths in Kentucky year over year from a year ago to now?
So I am aware of those, the escalation in opioid deaths as public health, and we are aware that there are other consequences of the pandemic. But
The escalation was about 50% year over year, correct?
the COVID-19 has been injurious in many ways.
Right. But a lot of people died from opioid overdoses who might not have died had the lockdowns not been put in place. Is that fair to say?
Objection, Your Honor, it calls for speculation.
Your Honor, I think he's just testified that he's aware that one of the consequences of the measures they've taken is increases in other aspects of our society, and opioid deaths is one of them.
And I think that was proper, but it's that second question that wants him to talk about the 50%, that's the one that calls for speculating.
Your Honor, I withdraw the question. Were there additional suicide deaths because of COVID?
Off the top of my head, I can't substantiate that one way or the other.
Okay. Would you agree that there was a significant increase in the extent to which the public suffered from depression because of isolation, unemployment, and all the rest that came from the lockdowns imposed by the government?
Your Honor, I want to present my same objection, it calls for speculation on behalf of the witness.
Your Honor, if he knows, I don't believe it calls for speculation.
I don't believe it calls for speculation. Yes, if he's aware or he agrees that it is, he either agrees or he doesn't, knows or he doesn't.
That's still an undecided. There's research as to whether it did or did not, but that is still undecided. So it's not settled science yet.
In your work with the governor and advising him, are you aware of any information that he and his other advisors have taken into account concerning the increased deaths caused from the effects of lockdowns?
Your Honor, I want to object to that as well. One on the relevance too, it assumes facts not. There's no record of any of these other conversations that Mr. Maddox is referring to.
Well, I'm asking him, Your Honor, if he is aware of whether these conversations took place. That's the very point.
I think it's a fair question.
So are you aware of whether the governor's counselors and advisors took into effect the implications for all these other secondary consequences from the lockdowns?
I can't answer it the way you described it, is because you continue to substitute lockdowns for the COVID-19 pandemic. The COVID-19 pandemic and the consequences associated with it have been terrible for humanity, including Kentuckians, where I do not acquiesce to the assertion that it's the lockdowns that have caused all those harms, or that there was a lockdown as you are describing it. Because in fact, there were measures that were taken and have been gradually titrated over the entire course of this response. And so COVID-19 has been terrible for humanity. I would agree with that.
So you don't consider when restaurants were ordered to close that was a lockdown?
Your Honor, I don't object to that question, but I think that's a misstatement. Restaurants never closed. They were always open. And there are limitations on how they could do their business, but they never, ever closed.
Okay. Thank you. You don't consider when restaurants were closed or restricted to takeout only, or when businesses were ordered shut down, or when schools were closed, or when nursing home patients were unable to see their family for months and months on end? You don't consider that a lockdown?
I'd like to object again, Mr. Maddox, the misrepresentations here, the schools never closed. For example, he is editorializing right now. If he wants to rephrase this question, that's fine, but that is a misrepresentation of the facts of what happened.
Let me correct Mr. Duke. The Jefferson County schools closed in March 2020 and reopened 2 days a week, Your Honor, in April of 2021. 2021, April of 2021. Kids go to school Monday and Tuesday, or Thursday and Friday. The rest of the time, they're not in school. So 3 days out of 5, those schools are closed to kids. And they were closed entirely for over a year in Jefferson County with 100,000 students. So I think I'm accurate in that respect.
It's my understanding that those schools, while they were not there physically on those days, they were also there virtually, and we can debate the merits of virtual learning till we're blue in the face, but those were the facts.
So your objection is that his question didn't specify closed to in-person?
My objection is, well, one, relevance, and two, is it's misrepresenting the facts of the situation.
Okay.
There's nothing else to say, Your Honor.
Okay. Yes, it's been clarified that the question refers to, based on the argument here,
Virtual learning versus
in-person
class.
versus
That's right.
closed to in-person. I think that's clear enough. That's
Thank
two relevance, so.
So you don't consider any of that to be a
Well,
lockdown?
I think you need to talk to the Jefferson Public School Board.
No, my question is, do you not consider that to be a lockdown?
We didn't impose that lockdown.
You gave the school district the option of closing, right? Because the state law requires the schools to be in class all but 10 days a year. And the governor's orders imposed under the emergency decrees allow the schools to close. Isn't that right?
It changed the financial disincentive if they chose to do that. But that was the decision of the Jefferson
Okay.
County Public School System.
I want to take you back to your testimony a moment ago. You indicated that hospital metrics are being tracked to see how the medical system is functioning, correct?
Yes.
Okay. So on your department's website, there are statistics for that. And when I talked to you in February, you complained that you didn't have them in front of you. Your Honor, may I have the witness look at a copy of this website?
You have one for opposing counsel.
I'm sorry, Your Honor, I don't. I'm just going to ask, and I'm not going to introduce this into evidence.
Okay.
These are the statistics from yesterday's website. And these probably
If you want a
help.
copy, I can get a copy.
I've got it right here.
Thank you, Your Honor. So you recognize this as the May 16 data, 2021?
Daily report, yes.
Okay. So this is the most recent data we have from your department, correct? Okay. Now, it shows that the current positivity rate is 2.79%, correct?
Yes.
Now, as I understand it, the World Health Organization and the CDC have said for about the last year that a positivity rate of less than 5% for 2 weeks in a row indicates that the disease is under control, correct?
No.
What's wrong with that?
Test positivity is a measure of testing adequacy. So 3% of 100 is 3, 3% of 1,000 is 30, 3% of 100,000 is 300. So you could test your way to a low test positivity rate. If you tested everybody every day, in the United States, you'd have 3 million infected people every day. So test positivity has to be interpreted in a much broader context. It is a misunderstanding or misapplication of that tool that it says that the disease is under control.
Well, Your Honor, excuse me, Your Honor. Dr. Stack. The Johns Hopkins University website, Coronavirus Resource Center, had a statement concerning this, and it said, on May 12, 2020, the World Health Organization advised governments that before reopening, rates of positivity in testing should remain at 5% or lower for at least 14 days. Do you disagree with that?
Disagree that Johns Hopkins has said that.
Do you disagree with that proposition?
I disagree with the use of it in isolation. So I think you have unfortunately misunderstood the science and then misapplied it. When test positivity is at that level, if other conditions are met, then yes, I could say the disease is under control, but I cannot use just test positivity as a single metric to determine the status of the disease.
Okay, well, I won't use it as a single metric. On February 18, when we last spoke, the positivity rate in Kentucky was 7.07%. On March 18, it was 3.23%. Are you aware of any time since March 18, 2 full months, where the positivity rate in Kentucky has been above 5%?
I have to have the data set in front of me.
So as you sit here, you are not aware of the positivity rate in Kentucky being above 5% in the last 60 days, are you, sir?
Yeah, but not in the context you're saying it. I have a whole lot of data points, and as you can see here, this is one day's report with all these pages. So I really will decline to validate one way or other what the positivity rate was on any given day or what the range was over the last 60 days. I came here today.
Okay, so
that
you just don't know,
I don't
correct?
know.
You're not testifying that it was in fact above 5% in the last 60 days, are you?
Testifying either that it was above or below.
And the court could take notice by going to your website and looking at the last 60 days to see what that rate was, correct? So in fact, it's gone down from 7.07 in February to 3.23 in March to 2.79 today, correct?
That's directionally correct.
Okay. Now, I want to show you the hospitalization data, because you said that data, those metrics are important to seeing how the system is working. On the second page of the website data, it shows that currently in the entire state of Kentucky, there are 381 people hospitalized with COVID, correct?
That's what the report says, yes.
Okay. And there are 4,916 available hospital beds that are not being used in Kentucky, correct?
Yeah, the availability statistics have been challenging. They're taking that from the federal.
Okay. So you
So
don't,
you-
you don't
you
agree with the statistics on your own website?
That's not what I said. I said that it requires more explanation. If you'd like me to, I can provide that.
Please.
So physical hospital beds and staffed hospital beds are not necessarily the same. This is derived from a federal survey where the questions are framed in a very specific way. So those would be physical hospital beds that may or may not be staffed. And it has to be interpreted in the context of, for COVID, the other table that you first referenced, that there are 381 hospitalized COVID patients. So whether or not, when there's only 381 hospitalized COVID patients, when the pandemic it was closer to 1,600, the fact that there is unused occupancy at the moment is determined by the hospitals based on other variables. So you have to interpret this whole thing in a context, in a bigger context than you're attempting to do by just pulling that one wrong.
So is the data for occupied hospital beds and available hospital beds and percentage of occupancy on your website, is that reliable and accurate data?
Using the numbers as the federal government asks us to, the hospitals to provide them, yes.
You wouldn't publish it if it wasn't reliable and accurate, would you?
That's misleading. That's misleading. The hospitals report the number of beds they have in the hospital and the number of beds that have people in them. Those numbers populate this, and we provide that as the federal government requires the hospitals to provide it.
All right. The other data showed the ICU percentage of occupancy is 58.9%, right?
That's what the chart says, yes.
And there are 112 people with COVID in ICU and 746 ICU beds available. Same concerns about the data that you just testified to?
Yeah, but I guess if you're asking me to affirm that these numbers are on the tables and to discuss how they're created to the extent that I can do it from memory, we can do that. It's not clear to me where you're going with this for what the relevance is. I'll just concede right here, the gray table is that because of the measures we've taken, because of the effectiveness of vaccines, is that the current COVID-19 hospital census on the left column at a disease rate that is similar to last summer looks much better than it did. So the steps we have taken, which include vaccines, have been so wonderfully effective that the hospital capacity is good. And so if you look over at the occupancy rate, that's all great. There's wonderful healthcare capacities, which is why we're able to lift restrictions now like we're doing, because we're in a much better situation than we were earlier in the pandemic.
Looking at regional statistics, Dr. Stack, Region 6 is where we are today. It's 9 counties, Boone, Kenton, Campbell, and some others. And there are a total, if I read this, of 22 COVID patients in that 9-county region, is that right?
That's what the table says, yes.
And a total of 3 in ICU in that 9-county region and 2 on ventilators, correct?
That's what it says, yes.
If you look at the last page of this document, it shows us the current overall incident rate per 100,000 of population, and that's 8.61, correct?
That's correct.
So how low does that number, first of all, how high was that number at the peak, say back in December?
We had numerous counties that reached points well over 100.
So it's come down 90% or more, correct?
It's come down a lot. In this, I won't dispute the general trend you're saying. I just can't give you the concrete percentage.
So my question is, how low does that number have to go before you recommend to Governor Beshear that the state of emergency due to COVID be ended?
And you contextualize that wrong, because I explained to you that the state of emergency has all sorts of other implications for relief that's important. People who need the relief for their businesses, unemployment insurance, various other types of aid the federal government is giving. But as far as the public health measures, those are the areas that I am most on point to advise the governor. And I have already said, and you can see in evidence, that we are lifting substantially all of the restrictions as of June 11th, as the governor has recently said. So from a public health standpoint, we are on that journey, but there are a whole lot of other complexities that have a lot of other implications.
Well, all you can advise them on is public health, correct?
Right.
So how low does that number have to go before you, as the public health advisor, recommend to the governor that the public health emergency be ended?
It has to be low in the context of hospital capacity, in the context of vaccine uptake, in the context of the known harm to individuals. But again, you're trying to get me to offer you a concrete number. It doesn't distill that simply. But I have already said, and I will repeat again, from a public health standpoint, the vaccines coupled with the interventions we've taken have gotten us to the point where we are lifting virtually all these restrictions because we feel it is now reasonably safe to try to do that.
On that point, Doctor, it's not just vaccines, is it? There's about 400,000 people in Kentucky who've recovered from COVID, right?
Probably more than that. Again, that metric is challenging, yes.
And those people have natural antibodies, don't they?
They should.
So those people are probably unlikely to get COVID to the same extent that I am, because I've had 2 shots of the Moderna vaccine, correct?
No, that's actually not correct. It appears these mRNA vaccines stimulate a stronger and more sustained immune response than the natural infection does. So that's why CDC still advises that even if you've had the infection, you still get vaccinated because the immune response is more effective.
Are you relying on a specific study for that proposition?
Relying on the expert guidance of the CDC and the Food and Drug Administration.
Well, are you able to provide it to me today, or can you provide it to your counsel so that they can provide it to me later?
We could go on the CDC's website where they give clear guidance that people who have been infected should still get vaccinated.
So I'd just like to ask if you can let Ms. Covage know where on the CDC website it demonstrates that the natural immunity is less effective than the vaccine.
Again,
That should be easy enough to do, correct?
you've inverted what I've said again. What I have said is the CDC advises that people who had the natural infection still get vaccinated because the immune response appears to be more durable in terms of strength and duration.
I think I just said because the natural immunity is less effective. You said because the vaccine immunity is more durable and longer lasting. And I think we're saying the same thing, aren't we?
Your Honor, we're happy to point to the place on the CDC guide, the CDC website where Dr. Stacks, and it'll clear all this up, and we'll provide a copy to the court.
That
I
would be
don't think you.
Thank you, Your Honor. Let me just wrap up this data, Dr. Stack. If you look at page 4 of the document, it shows you there were 287 new cases yesterday. Now, actually, only 218 of those cases are confirmed. 69 of those are probable. Can you tell me what a probable case is?
I can get conceptually, I can describe it, but there's specific criteria. Probable would be someone who has symptoms and was exposed to COVID, and the two things combined create the high likelihood that they have COVID, or they had an antigen test, which is different than a PCR test, and is a little less reliable in some ways, plus symptoms, and the two things combined make it likely they have COVID. A confirmed case, in order to be a confirmed case, you have to have a high-quality laboratory polymerase chain reaction test.
Right.
So probables most likely are actually COVID, but they're distinguished from confirmed, which is a specific laboratory test combination.
Speaking of that confirmed laboratory test, do you know what cycle threshold Kentucky's using for its testing?
Currently, the federal government has, it's actually, the American Public Health Laboratories have guidance that is not to be used, and the federal government in the regulation of labs explicitly precludes using that as a measure to be imported with labs because it varies from machine to machine, from analytic platform to analytic platform, and can be manipulated in a laboratory. So cycle threshold, but yes, I'm familiar with cycle threshold, which would be a way to ascertain the relative quantity of viral load in someone's system.
And you don't know what Kentucky's using?
Well, because federal regulatory guidance says labs may not report that as part of a diagnostic test, Kentucky does not apply standards to that.
All right, so on page 4, we have the number of new cases by county in Kentucky. And if you look at the right-hand column, all of those counties have no cases. The column to the left of it, there are only 3 counties that have any cases and only 1 each. And in the second column, there are most of the counties only have 1 each. So as I count this up, there are 57 counties in Kentucky with no cases of COVID, new cases, and 24 counties with only 1 case. So what's that, 81 counties where it looks like there's a total of 24 new cases of COVID. Is that an accurate reading of that?
Yeah, if you've just done simple math and approximated, yes.
Okay. And then finally, on the last page of the data, we've got the incident rate per 100,000 for Boone County of 7.2%, Kenton County of 4.1%, and Campbell County of 1.5%. Doctor, if the entire state of Kentucky were an incident rate of 1.5%, would you recommend that the emergency be ended?
You know, I think, and I'm going to observe as we do this in court here. So you use the terminology 1.5%. It's not a percentage at all. It's an absolute number per 100,000 people.
Thank you for correcting me on that.
You're welcome. But and I'm happy to do that. A big part of my job is education. But I think it demonstrates why the uninformed can well-intentionally reach.
Doctor, I just read the bottom of the document wrong. I understand what a percentage is, so please don't be too condescending.
Yes, per incidence rates. It's not a percentage,
Right.
though. It's an absolute number.
Right.
And so, in this case, the incidence rate is calculated based on knowing the number of people who are infected in a jurisdiction. And so some of those counties have not had many tests done either. But directionally, this is wonderful news. This is fantastic that the incidence rate has come down much lower.
So the question was, if the entire state of Kentucky had a 1.5% incident rate, would you recommend that the emergency began?
I've asked them about this. I would, when the disease is under control and the risk is abated, I'll recommend that the public health threat has largely subsided. But the state of emergency has a lot more administrative implications. That's a whole, much more multi-dimensional.
So I just got one more line of questions, I'll be done. In February, Doctor, we were talking about the trend line and the like, and if you remember, I pointed out that in July, when the mask mandate went into effect, there were 432 cases, and in December, precisely 5 months later, there were 4,300 cases, and you educated me as to why that didn't demonstrate that the measures were ineffective. In the course of that, you said that I had created a false equivalency and that you had interrupted the exponential climb of disease. It's at page, it's page 69, at the close to the bottom. And you said that you had interrupted the exponential climb of disease, that where it was uninterrupted in states where they did not take measures, no mask mandate in Tennessee or the Dakotas, where they really didn't take much measure at all, they had 2 to 4 times higher death rates as a result. You remember that? I can show you a testimony.
No, I remember that.
So my question is, where did you get the idea and the data suggesting that Tennessee, for instance, had a 200 to 400% higher death rate than Kentucky?
Right, so, and again, these are like photography, not a movie reel for some of these. So at that time, when we were exiting the winter surge in disease, if you looked at the rate of death that was happening in the state, like I think South Dakota, was worse than North Dakota as it turned out. At that time, the rate of death was substantially higher. If you looked at an incidence rate, the number of new deaths per population, it was much, much higher. When you look now over the longer duration and the total journey, those snapshots in time sort of get lost as you move on. Let me give you one other example just to make it more clear. A lot of people died in New York, in the state of New York early on. They got hit at the very beginning before we knew how to treat the disease, before we had necessary personal protective equipment to protect healthcare workers. They got hit very early on and paid a much higher cost in terms of life because we were far less prepared then for it. As you go along and then you get to the Dakotas, they went through an intense period that was very, very high. And when we had our last discussion in Franklin County, we were just exiting that. And so the incidence rates were much higher. And that's, I think I alluded to at that time of hearing. I know I did. I had no notes in front of me and had to do these things for much. But the incidence rate for death from COVID for South Dakota and for Tennessee are both higher. But when you look at where we are now, if you were to look today in the data set, it's not 2 to 4 times higher. At that moment in time, the rate of death was higher for sure in the Dakotas by far than in Kentucky. So I just going to acknowledge that depending on when you draw the line for the data, it does look different as you go over time.
So generally, I think what you're saying is if I go back to February data or data available in early February, I would likely see a much higher difference between
the delta. You had that for that 2-month period, like that.
Correct.
The peak, I guess.
Okay. So finally, let me just ask you this. So there was some testimony earlier today and some data introduced that's being taken under consideration by the court. It hasn't yet been entered yet, but the data for Florida, and you agree that Florida had much less stringent restrictions than Kentucky, correct?
No, I just want to reiterate the same objection that was on the record earlier about this data.
Yeah, I understand.
With regard to the exhibit, it's the thing that's under consideration. I don't think there's probably any questions about the data.
Right.
I just don't know if I'm going to accept it.
Understood. Thank you.
You understand.
You agree with me? I agree. I believe that Florida had less stringent restrictions than Kentucky.
Yeah, at varying times, they had much less stringent requirements at varying times.
Okay. And they opened up months and months ago, didn't they? I mean,
They opened up earlier than us, and yes, you had to go on the exact time.
so the data that it's been what's marked for for identification as Exhibit 26, and was testified to by another expert witness, is that in Florida, the deaths per 100,000 is 167.59, while in Kentucky it's 150.94. And I'm not going to ask you to verify those numbers.
No, so I can't verify Florida, so I'm familiar with Kentucky's, and I can say, and you're taking the total death overall for the whole journey of the pandemic.
Correct.
So it's a cumulative measure.
Correct.
I probably, that's correct. I'm going to defer that you have accurately read the webpage in Florida.
So as I read that, just comparing 167.59 to 150.94, it's essentially 100, it's 11% more in Florida than in Kentucky. 167 compared to 150.
Yeah, mathematically, that's probably correct. I don't think I used Florida as an example, but.
Correct, you did. But it's a state that's a much larger state. It's got a much older population. In fact, the deaths per 100,000 of 65 years old and older in Florida is 817 compared to 898 in Kentucky, if this data is correct. And I think we could probably verify one way or the other, even if the exhibit doesn't come in, that the data is correct. So that would mean that Florida deaths of 65-year-olds, people like me, and older, is 91% of Kentucky's, and yet they have less stringent restrictions. Do you have an explanation for that?
Yeah, and again, it's because you have to be careful not to take one single metric and take it out of context. So depending on the metrics, as you look from state to state to state, you'll find different performances across different indicators. Florida did go through phases where some of their major metropolitan areas were severely strained for their healthcare capacity, and where things that were coded as COVID deaths, there may have been other deaths that were not COVID, but were caused because people couldn't get care because the hospitals were overrun. This is part of the challenge of using this kind of mortality data in real time, because this will be one of those things we look back a year or two from now and have a lot better benefit of perspective. But I think that's the same table that the other doctor was discussing.
Correct.
That apparently showed that if what she said was correct, she represented that Kentucky was the lowest in terms of mortality on the entire table, and also the second lowest over a certain age. Is that the same table? Right. So I would not assert that we were perfect. I in fact have acknowledged that we were not perfect in our execution of our tasks, but we sure appear to have done, in a balanced scorecard kind of way, a very overall good job for mitigating harm.
Do you know, though, how the depression level, suicide level, opioid overdose level, economic dislocation level in Florida compared to that we experienced in Kentucky? You talked about the public health outcomes, but what about the other outcomes?
Yeah, so I don't have that in front of me today to be able to opine about different aspects of societal performance across the different states.
Right.
But again, my dispute and the way you represent these when you do is that the assertion is that it was the actions that were taken in the state to mitigate against the disease, as opposed to a number of variables that were inevitable because of the pandemic and the infection itself and the harm it caused in society. So I think that's where we might just have to say reasonable people can reasonably disagree.
Fair enough. Let me just finally end by asking you, you agree that the science says that because I've been vaccinated and it's been more than a month since my second shot, I don't need this mask, right?
Well, again, you've become accustomed to me giving you longer answers, but I want to be clear. The science that is evolving has shown that, yes.
The science today.
As of today.
Right.
But this has changed as recently as over the last few
Sure.
years. And so as we learn more, yes, it does appear that if someone is fully vaccinated with one of the 3 approved vaccines in the United States, that yes, that you can walk around without that mask without substantial likely harm to yourself.
Or to you, right? I'm not going to
Because
infect
I'm
you.
vaccinated too.
But even if you weren't, I wouldn't be infecting you, would I?
That's untrue.
Why is that false?
because people who are vaccinated can't get infected, in fact, have gotten infected.
But doesn't your guidance say that I can walk into public places and I don't need a mask?
It does, because it's risk mitigation, not risk elimination.
Finally, there was testimony earlier from another expert, Mr. Petty, who indicated that when I put this cheap Chinese mask on and I wear it this way, there's lots of areas where there are gaps, here around my nose and here on the side of my face. And he testified that if there was a 3% leakage around the mask, that it has effectively zero efficacy. Do you have any information to the contrary?
Well, what I'd say is that the expert who sat up here before offered his opinion based on his domain of expertise. In the public health literature, the World Health Organization, the Centers for Disease Control, and the overwhelming number of state health officials in the United States of America have reviewed a broader evidentiary base that also includes contact tracing findings, very site-specific application of masking where people did or didn't get infected, USS Roosevelt aircraft carrier where people were wearing masks, and have found, and in fact that was the reference that Ms. Cubbage referenced in the Journal of the American Medical Association, that in fact masks have mitigated against the spread of this disease. If you're going to talk in a very narrow role of expertise, someone who deals in aerosolized particles, and can aerosolized particles evade around the gaps? The CDC has acknowledged that. In fact, that's why they talked about double masking, to seal up those gaps around the barriers. But to say that the mitigation tool is imperfect is not the same thing as saying it's ineffectual. And there is a large body of other scientific evidence that says that those masks have staying lives.
Do you know why Dr. Fauci originally recommended that there not be any use for masks, that nobody wear masks in public?
And that's taken out of context. It was at a time,
I saw it on television.
it was taken out of context. It was said at a time when the evidence wasn't established, the routes of transmission of the disease were not clearly known, and when personal protective equipment was scarce, healthcare providers didn't have adequate access to it. So to have the average American go out and secure all those materials when the healthcare workers then would also not have it, and when the evidence did not yet support it, was premature. As we learn more, our opinions have evolved, our recommendation, our guidance has evolved. That's why I can sit here today and say on June 11th, most of these restrictions will go away, because we've learned more and we've had ways to effectively intervene. Dr. Fauci made a comment, and I'm not going to defend or attack Dr. Fauci. He can own up for his own comments just like I'll have to mine. But at the time when people said that mask wearing was not universally recommended or required, that was where the current state of understanding was. Things changed with more information and they evolved.
Doctor, will the emergency be over on June 11 when all the restrictions are lifted?
I decline to provide that answer, as I've said before. It's not mine to make, it's the governor's to make.
Thanks very much. Thank you.
One question, I just want to make sure I heard correctly. I believe the testimony was that with regard to the PCR cycling threshold, the federal government has ordered labs not to disclose that. Is that what you said? I don't, so you might have said why, and I didn't hear that. That was the question. I just would like to make sure I understood correctly rather than looking at the data.
So I can get you this document I can give to, if that's appropriate, from the American Public Health Laboratories, but laboratories that bill Medicare and Medicaid, which are the vast majority of medical labs, are regulated, and they have to follow certain regulatory guidance that comes from, I think, the Centers for Medicare and Medicaid Services down through, and that is enforced by state government through our Office of Inspector General. And in those lab, and I may have the path incorrect, but there's a path like that. And they are not, so you have to have in those regulatory guidance, if you say a white blood cell count for infection, then you put a range for what's the range that's normal for almost 95% of the people. For cycle thresholds, because of that, the limitations of that particular metric, the federal regulatory guidance says that it's not to be used as it reported to the public as part of a diagnostic test. And so because of that, laboratories who are subject to those regulations don't report it, because where they report it that way, they could face regulatory oversight varying consequences. So we can look into that, but there's a document from the American Public Health Laboratory Association that very clearly describes this.
situation.
Then finally, council, you would ask some questions based on what was identified as Exhibit 26, and indicated there would be data that you would present or could be presented. I don't know if there's going to be a briefing schedule where you present something that the court can take judicial notice on in the event and then accept that, or if there's something that all parties would agree the court can take judicial notice on. If I need to refer to specific death rates or things like that, if this exhibit is excluded.
Your Honor, my thinking was that if the proper foundation hasn't been laid for the exhibit, then I suspect that the data itself can be verified, and just as you suggest, we would likely include it in our briefing with appropriate citations to the sources.
Right. Your witness for any questions on direct that was asked on cross?
Can I just find one to follow on your own question, Your Honor? Doctor, could you provide the document on cycle thresholds to your counsel?
Yes, I'd be happy to.
Thank you.
Thank you.
Your Honor, the Commonwealth has no further questions. We'd like to, if the court would allow 10, 15-minute break. I think we have one more witness
I
left.
probably appreciate a break myself. We'll recess for 10 minutes. We'll be back on board.
All right.
research issue, where you can't be communicating. It's good.
That's why.
Yeah, I'll file one.
All right, please.
You may be seated. Okay. Didn't have to correct. Would you like to call?
But first, John, just for the record, is Dr. Sachs sees we had that for the redirect, we want to clarify that for the record.
I think that was clarified, that there was no additional. If there's no additional questions for redirect, then there will be no recross, so. You're free to go, or free to stay, if you wish.
And Your Honor, we did have one other witness that we did subpoena, but we have released him from the subpoena, so we almost did not intend to call any of the witnesses today.
Well, then I guess it's just a matter of confirming post-hearing briefing. I know the defendants have indicated for a reply, they could do it, I think it would be by May 24th, but if there's other things that need to be submitted, I don't know what the timeline or scheduling should be on that one.
Your Honor, on the law of the case, I think I'd like to file just a couple pager. That would be okay. There is a case law on this with a temporary and a permanent injunction, and I could probably do that. There's actually a case that's directly appointed to the U.S. Supreme Court. I could either file a brief, or I could simply cite the case to the court, whatever you want to do.
Well, on that issue, I do want to see that, so that's something we'd like to have.
Yeah, we have no objection to Mr. Lee's filing contemporaneous with us, if you would like the whole week, and us file contemporaneous with us.
If we do that, just everybody file a simultaneous reply or whatever you want to style it as by May 24th, is that enough time for
Yes,
everyone?
Your Honor.
Because I've read everything that's been filed so far, so I don't expect there should need to be a whole lot, but, other than you would have the right to reply to, Attorney General's. All right, anything further?
Unless the court has questions for us, or anything you felt like we should
Well, anticipating that there might be oral arguments, I had questions. I think some of those questions were actually resolved somewhat today. And I don't know that I would need to get into it. I think it's probably.
If Your Honor has questions after the briefing, we're happy to make ourselves available for a Zoom
That's probably
hearing.
the better way, because a lot of the questions I had were, defense counsel, you didn't follow it, so. I think that's, if I have questions, I'll notify everyone, we can either do, teleconference, whatever it would need to be, but I don't expect, I should have, I think most of what I had we addressed or will likely be done. All right, thank you all very much. We'll take it under submission, I guess, if it's on the 24th that it's filed, it'll be on the 25th.
Thank you.
You can keep it if you want it, I figured you might want to read it.
Well, it's easier to, I keep stuff.
No, you can keep it.
Okay.
What is
Stop.